There are two major divisions of the nervous system: the central nervous system, which will be known as the CNS, and the peripheral nervous system, known as the PNS. Understanding how they work together is the foundation for interpreting neurological assessment findings and recognizing neurological disorders. The CNS is the command center and includes the brain and spinal cord. The PNS is the pathways and includes all the nerves that branch from the CNS to the rest of the body. So remember, C for CNS is command center, P for PNS is the pathways. Damage to the CNS, such as in a stroke or spinal cord injury, causes loss of function below the level of the injury, while the PNS disorders, like polyneuropathy, cause distal sensory loss and weakness. The nervous system workflow. The sensory input from the PNS detects touch, pain, temperature, position, vision, smell, and hearing. The CNS interprets that information and integrates it into thinking, decision-making, and planning movement. The CNS then sends signals back through the PNS to muscle glands. In a spinal cord compression injury, sensory signals come in, but motor signals can then not go out, which leads to hyperreflexia, clonus, and weakness. In MS or MG, communication between nerve and muscles is disrupted. Fatigue, weakness, and coordination issues arise. These are higher level nervous system functions that keep the body stable and responsive. So homeostasis is the nervous system regulation of heart rate, blood pressure, respiration, temperature. This is often through the autonomic pathways. So in a patient with increased ICP, they will have changes to respiratory drive and blood pressure that occur, such as Cushing's triad, which then reflects through disrupted homeostasis. Thinking, memory, judgment, language is primarily controlled by the brain's cortex. In patients with Alzheimer's or another major neurocognitive disorder, they will show a decline in cognition that affects daily tasks and safety. Your reflexes, Your reflexes are rapid involuntary responses controlled through the spinal and the PNS. Examples: hyperactive reflexes and clonus occur with a spinal cord compression. Absent reflexes occur with peripheral nerve injuries such as polyneuropathy. I want you to think about if a patient has sensation intact but can't move the limb, which part of the pathway is likely affected? Sensory input, integration, or motor output? So let me link all of this to your prior knowledge. So you have assessment of the patient. So your assessment is that your patient has numb feet and an absent Achilles reflex. Your interpretation then is going to be that they have a peripheral nervous system disorder, such as polyneuropathy. You're going to want to teach your patient to do daily foot checks and implement fall precautions. I want to emphasize safety and prioritization. In CNS injuries such as strokes, TBIs, or spinal cord injury, these require priority interventions to protect the airway, so your A's, your perfusion, which is your C's, and your neurological functioning. PNS injuries require protection from injury due to sensation loss, impaired mobility, or autonomic dysfunction. So let me tie this to clinical scenarios. You have facial droop. That's a stroke alert. So you're going to want to make sure your patient has their airway protected, that they're perfusing properly, that they're breathing properly. In a patient who has neuropathy, they have the loss of protective sensation. So we want to make sure that they're practicing good foot care. So in a stroke patient, and they're exhibiting right-sided weakness and facial droop, the CNS integration and motor output is affected, you're going to activate your stroke protocol. In patients with polyneuropathy, which affects your PNS, your patient's going to report tingling, numb feet, and absent reflexes. They're going to be on fall safety precautions and educated about foot care. Lastly, a patient with a spinal cord injury at T6, which will cause loss of movement and sensation below that level, their reflexes become hyperactive, and we want to maintain spinal precautions. The CNS and PNS work together as an information highway. When you know where the breakdown occurs, sensory input integration or motor output, you can then interpret neurological symptoms quickly and intervene safely. Let's take a deeper dive into the CNS, the core control center of the body. Remember, the C in CNS stands for the command. The CNS includes the brain and spinal cord, and its job is to interpret sensory information, make decisions, coordinate movement, and maintain homeostasis and supporting cognition. The CNS is divided into those two major structures: the brain, which the brain handles the integration of sensory information, cognition, emotions and behaviors, regulation of autonomic functions, and initiates the voluntary motor activities. So if you have a patient who had a stroke, and that stroke affected the frontal lobe, this is going to cause problems with speech and decision making. The increased intracranial pressure, or ICP, affects the brain function, causing a decreased level of consciousness, which is the earliest sign of deterioration. The spinal cord is the pathway for sensory input. It is the road that travels to the brain. It is the pathway for motor commands, or the road that travels back to the body. It controls reflex arcs, like knee jerks or withdrawal reflex. The clinical correlation for this is a spinal cord injury that has disrupted the communication below the level of injury, which causes sensory loss, motor weakness or paralysis, and autonomic dysfunction. Hyperflexia and ankylosing indicate the upper motor neuron involvement, which is often due to the spinal cord compression. The CNS interprets information from the PNS, such as pain, touch, proprioception, and visual auditory input. In a stroke patient, the sensory extinction or neglect is a cortical level deficit. In motor control, motor neurons in the CNS initiate and coordinate movement. So in Parkinson's, when your dopamine loss occurs in the CNS pathways, it then causes that bradykinesia, tremors, and rigidity. Spinal reflexes provide rapid responses without requiring the brain. Patellar reflex testing helps identify spinal segment integrity. The CNS supports memory, judgment, or orientation. In Alzheimer's disease, it causes a progressive deterioration in the cerebral cortex, which worsens cognition and function. The brainstem centers regulate homeostasis. It regulates your breathing, heart rate, blood pressure, and temperature. Brainstem stroke can compromise respiratory drive, requiring rapid intervention. I want you to think about if a patient suddenly becomes confused and difficult to arouse. What CNS structure is likely affected and why? I want to link this to prior knowledge using assessment and interpretation into action. Your assessment: your patient has unequal pupils and a deteriorating level of consciousness. You're going to use your interpretation as a CNS dysfunction and likely increased ICP. As a nurse, your interventions are to elevate that head of bed and maintain airway, notify the provider, and minimize stimulation. This reinforces neuro-emergency decision-making. Key safety priorities. Airway first anytime the level of consciousness decreases. Recognize stroke signs early using FAST and NIHSS, which you will later learn. Report new weakness, paralysis, or sensory loss immediately. Monitor for signs of herniation, dilated pupils, or Cushing's triad. Some clinical examples. A TBI patient becomes drowsy. The ICP rises to 22. You, as the nurse, need to restore head alignment, reduce stimulation, and notify the provider immediately. You have a patient with sudden facial droop and slurred speech. You're going to, as the nurse, activate the stroke alert, obtain a CP, and keep them NPO until the swallow screening. You will have orders for the above. You have a patient who has a loss of motor function below T6. You will maintain spinal precautions and complete frequent neuro checks. In a patient with Alzheimer's with gradual memory loss and disorientation, you will reinforce routines and have safety modifications. Note that any changes in the brain or spinal function can rapidly impact movement, sensation, behavior, and safety. Early recognition of CNS dysfunction is a cornerstone of neurologic nursing care. Now we're going to dive deeper into the PNS, all the nerves outside the brain and spinal cord. The PNS is responsible for carrying information to the CNS and carrying responses from the CNS back to the body. As the CNS is the control system, the PNS is the delivery and feedback network pathways. The PNS has two major divisions: the somatic nervous system, which controls voluntary movements, such as skeletal muscles, conscious sedation, including touch, pain, temperature, and position. So when you have a patient in which the somatic PNS is damaged, such as in polyneuropathy, they lose sensation in a stocking glove pattern, developing weakness and showing diminished or absent reflexes. In turn, for nursing considerations, this increases the risk for falls, burns, and foot ulcers. The second is the autonomic nervous system, or the ANS. It controls the involuntary body functions, such as heart rate, blood pressure, digestion, sweating, and bowel and bladder control. This system includes the sympathetic, fight or flight, the parasympathetic, rest and digest. Clinical correlation is in spinal cord injuries above T6. Dysregulated sympathetic activity can trigger autonomic dysreflexia, which is a life-threatening hypertension emergency. And polyneuropathy, ANS involvement causes orthostatic hypotension, bowel and bladder dysfunction, and altered sweating. In Guillain-Barré syndrome, a demyelination of peripheral nerves leads to ascending weakness. It reduces reflexes and provides a respiratory risk. In myasthenia gravis, impaired ACH receptor function at the neuromuscular junction causes muscle fatigue, especially when chewing, swallowing, or breathing. I want you to think if the patient has loss of sensation in both feet, but cranial nerves are normal, which system is likely affected, your CNS or your PNS, and why? We're going to link to prior knowledge. Your assessment of your patient revealed burning, numbness in feet, absent Achilles reflexes, and unsteady gait. This is likely a polyneuropathy. As the nurse, you will implement fall precautions, teach protective footwear and daily foot checks, and assess the foot integrity. Safety and prioritization includes preventing injury from sensory loss, preventing falls, monitoring for respiratory involvement, and addressing autonomic instability. Whether from neuropathy, neuromuscular disorders, or autonomic dysfunction, patients lose sensation, strength, bounce, or physiological stability. Recognizing these patterns early ensures intervention and keeps patients safe. Neurons are the basic working units of the nervous system. They communicate information through electrical and chemical signals. Understanding neuron structure helps understand neurologic symptoms, medication actions, and disease processes. So the neuron structure, it has three major parts. The dendrites, which are the branch-like extensions that receive incoming signals from other neurons. They are the input zone. The cell body, or the soma, contains the nucleus. It integrates incoming information, and it is the decision center for whether the neuron will fire an impulse. The axon is a long fiber that carries electrical impulses away from the cell body, sorry. It can be over 1 meter long. It ends in axon terminals that release neurotransmitters. The myelin sheath is the fatty insulation around the axon. It speeds up conductivity dramatically. It is produced by the oligodendrites and the Schwann cells. The oligodendrites are part of the CNS. The Schwann cells are part of the PNS. So if a patient presents with damage to the myelin, such as multiple sclerosis, it's going to slow or block nerve conduction and produce symptoms of weakness, numbness, or even vision problems. So your neuron functioning. The neurons generate action potentials, or electric signals, which are impulses that then travel to the axon. At the synapse, the neurotransmitters, whether it be acetylcholine, dopamine, or GABA, transmit signals to the next neuron or muscle. So this matters in nursing because in conditions like MS, it affects the myelin, so it has conduction failure. In conditions such as myasthenia gravis, or MG, it affects the acetylcholine receptors, and you will have neuromuscular weakness. With Parkinson's, it affects the dopamine, which then causes a movement disorder. Seizures occur due to uncontrolled electrical activity. This will connect the physiology to the pathophysiology later in the neuro content. So think about what part of the neuron receives the signals, the axon or the dendrite. And let's link some prior knowledge to what you just learned. Your patient with MS reports new leg weakness and numbness. You interpret that as the demyelination slows conduction in motor and sensory pathways. Your action is to notify the provider, cluster care to reduce fatigue, and monitor mobility and safety. This will help you as a student to connect the neuron structure to the clinical symptoms you are seeing within your patients. I want to place emphasis on using neuron function to teach safety. In patients with MG, they have impaired neuromuscular transmission, which then causes swallowing difficulties. These patients will need to be NPO until they are evaluated. In neuropathy, impaired sensory neuron function leads to daily foot care checks and fall prevention. In stroke patients, sudden failure of neuronal pathways, you will activate the stroke protocol immediately. This shows why understanding neurons is essential for safe nursing care. So let's do some examples. You have MS, which we know is demyelination. So you are having damaged myelin, which slows your conduction. Your patient will present with fatigue, weakness, and visual changes. Why? Because the myelin sheath function directly correlates with neurological deficits. You have a patient with myasthenia gravis. In this patient, the acetylcholine can't bind well with the neuromuscular junction. So your patient is going to become weak with repeated activity. So here, this is a synaptic transmission issue, not the nerve or muscle itself. If your patient's having seizures, you're going to see that sudden electrical overactivity or neuronal networks present as convulsions. You're going to give an anticonvulsant with order to stabilize the membranes or increase inhibitory neurotransmitters. In patients with Parkinson's disease, the loss of dopamine-producing neurons disrupts signaling in the motor pathways. This patient's going to present with bradykinesia, tremors, and rigidity. The medications that are used increase the dopamine availability. Every neurological symptom we assess, from weakness to tremors to confusion, stems from how the neurons are communicating. If you can understand neuron structure, you will then understand almost every neuro disorder that we are going to study. We're going to dive a little bit into a neurologic assessment, which is the health history as your foundation. Before you touch the patient or perform any exam, you need to gather information that helps you predict what deficits you should be looking for during your physical examination. You have a patient that comes in with any neurological issue. You want to focus on the three big categories: chief complaint, onset, and duration. What brought you in today? When did the symptoms start? And did they come on gradually or suddenly? Why does this matter? So, sudden symptoms indicate a stroke, which require immediate intervention. So this is your emergent versus urgent. This is going to assist in your prioritization questions on your NCLEX. Gradual symptoms indicate a chronic disorder. A patient reports sudden right side of weakness beginning 1 hour ago. This is likely an acute stroke. An active stroke protocol must be activated immediately. This is an emergent situation. A patient comes in with chronic numbness and tingling of their feet. This leads to neuropathy or polyneuropathy, which is a chronic condition, not emergent or urgent. Ask about the past neurologic disorders or medical history. Have you ever had a stroke or TIA? Have you had a brain injury or a head trauma? Do you have a history of seizures? Do you have a history of neuromuscular disorders such as myasthenia gravis, multiple sclerosis? Are you a diabetic? Why do these matter? Because previous neurologic events guide what deficits might return or worsen. Chronic diseases such as diabetes and hypertension increase the risk for stroke or neuropathy. Medication history and family history. Ask about anticonvulsants, dopamine therapies, or MG medications. Blood thinner knowledge is crucial in a trauma or stroke. Have you had any recent medication changes? Family history of early strokes, dementias, or neuromuscular conditions. Why does this matter? Because suddenly missing an MG medication can cause a myasthenic crisis. Too much MG medication could cause a cholinergic crisis. So a patient develops drooling and worsening weakness. They admit that they accidentally took extra MG medication. You're going to suspect a cholinergic crisis and notify the provider immediately. Ask yourself which symptom onset is more concerning, sudden or gradual, and why. Think back to how you prioritize. I want you to remember, in doing neurological assessments, we want to focus on urgent versus emergent versus chronic. So let's go with this patient. Your patient says, my speech became slurred 20 minutes ago. This is a neurologic emergency until proven otherwise. You will activate the stroke alert, determine last known well, keep NPO, and notify the provider. For safety, sudden changes in speech, vision, strength, or consciousness require immediate action. Those are urgent. Remember to take a medical history that can prevent life-threatening mistakes, such as giving contraindicated drugs. ask about headaches, trauma, or seizures. Safety priorities to always follow with the Neuro rule: airway, level of consciousness, pupils, motor function. You have a patient who says their face went numb 30 minutes ago. This is a time-sensitive emergency. You have another patient who says they've had a worsening headache, vomiting, and feel very sleepy. This is a red flag for IICP. You're going to elevate your head of your bed, align the neck, and minimize stimulation. You have a patient with seizures who said they missed their seizure meds for 2 days. They are at a high risk for seizure breakthrough, so you're going to reinforce compliance, monitor, and implement seizure precautions. The neurologic health history gives us the first clues about what part of the nervous system might be affected. By understanding onset, risk factors, medications, and previous conditions, as nurses, we can predict what deficits to look for and how to act quickly to ensure patient safety. After gathering the neurologic health assessment, the next step is to complete the physical exam. A neuro exam assesses how well the brain, spinal cord, and peripheral nerves communicate. We'll focus on the level of consciousness, pupils, motor and sensory systems, and reflexes. These findings guide urgent decision-making, especially in stroke, increased ICP, trauma, and seizure disorders. The level of consciousness is the earliest and most sensitive indicator of a neurocognitive decline. You may use voice commands such as open your eyes, painful stimulus such as nail bed pressure, or even the Glasgow Coma Scale, GCS scoring. Your clinical example is a TBI patient who was alert, now only responds to pain. This is an early sign of rising ICP. You're going to want to raise the head of the bed, maintain airway, and notify provider immediately. Pupillary responses. You want to assess size, equalness, shape, and reactivity to light. Pupil changes indicate brainstem function and possible cranial nerve 3 compression. A patient's pupils will change from equal and reactive to unequal and sluggish. This may signal a herniation. This is an emergency and will require a neuro evaluation. You want to monitor for function, assessing strength bilaterally, drift, symmetry, movement against resistance. You're checking for weaknesses, paralysis, and posturing. Clinical relevance. In right arm drift and facial droop, this could likely be a left-sided stroke, and you know to activate the stroke protocol immediately. To test sensory function, you will use light touch, pain, check temperature, vibrations, and proprioception. Sensory loss indicates abnormalities in peripheral nerves and spinal cord or even brain pathways. In patients with polyneuropathy, you want to initiate fall precautions and institute daily foot care. Deep tendon reflexes. You would test those deep tendons located in the biceps, triceps, patellar, Achilles, and brachioradialis, as well as the Babinski. Brisk reflexes and ankylosing indicate upper motor neuron lesions, which is common in spinal cord compressions. As an LPN, you will not check the deep tendon reflexes. I just want to make you aware that this is how it's tested and where it's tested and why it's significant. I want you to pause and think about which finding is usually the earliest indicator of neurologic deterioration. Let's link the prior knowledge with the assessment of a patient reports sudden numbness and arm weakness. You know that this is a neurological deficit that indicates a possible stroke. Your nursing interventions are to activate the stroke alert, obtain the last known well date, keep the patient NPO, and perform NIHSS. Always prioritize airway first if level of consciousness decreases. New onset weakness, facial droop, or slurred speech is always an emergency. Unequal pupils could possibly be herniation, also an emergency. Post-seizure patients maintain a side-lying position. These findings all demand rapid response to prevent secondary brain injuries. The neurological physical exam isn't just a checklist. It's your window into how the brain, spinal cord, and nerves are functioning in real time. Accurate assessment, rapid interpretation, and immediate action keep neurologic patients safe. Let's summarize the most common diagnostic tests used to evaluate neurologic conditions. Each test provides different information. Some are going to show structure, while others show blood flow, and others even evaluate electrical activity. Understanding what each test does helps us as nurses to prioritize our care. A CT scan is the first test for acute neurological changes. It identifies bleeding, skull fractures, large strokes, and mass effects. It is very fast and essential in emergency stroke evaluation. A patient arrives with facial droop and slurred speech. The CT will rule out hemorrhage before thrombolytic therapy is induced. A negative CT points towards an ischemic stroke. An MRI is more detailed than a CT. It's going to detect the soft tissue changes, tumors, demyelination such as an MS, and even small strokes. It is used when a CT is inconclusive. So in a patient, early MS lesions might be missed on a CT, but they're clearly visible on an MRI. A lumbar puncture is used to analyze cerebrospinal fluid. It's used to diagnose infections such as meningitis, inflammation, and even autoimmune diseases or subarachnoid hemorrhages if the CT is negative. Critical safety note: never perform an LP when increased ICP is suspected due to risk of brain herniation. A patient comes in with headache, fever, and neck stiffness. The LP is going to confirm meningitis. An EEG, which records the electrical brain activity, is used to diagnose seizures and even differentiate seizure types, as well as monitor abnormal electrical patterns. A patient who becomes unresponsive without visible convulsions may have non-convulsive seizures detected only by an EEG. An EMG measures the muscle response to nerve stimulation. It helps diagnose neuromuscular disorders such as MG and neuropathy. The EMG shows reduced muscle response in myasthenia gravis. A cerebral angiography visualizes cerebral blood vessels. It can detect aneurysms, AV malformations, and even vesage blockages. It is often used when stroke symptoms suggest a large vessel obstruction, and it will guide the thrombectomy. Think about which test must be used before giving TPA for a stroke and why. Assessment: the sudden onset or facial droop plus arm weakness. Interpretation is potential ischemic stroke. Your action is to determine last well known and start the stroke protocol and prepare your patient for a CT scan. Remember the big 3 rule for neurosafety: CT first in any acute neurological change as it rules out hemorrhage. Never assist in performing an LP if increased ICP is suspected, and an EEG for unexplained changes in consciousness. It will rule out those silent seizures. Clinical correlation: in a TBI patient, the CT will show subdermal hematoma. This patient needs prep for this patient needs a neurosurgical evaluation. In polyneuropathy, the EMG will show diminished nerve conduction in the feet. This confirms the PNS involvement, and your nursing interventions should include fall precautions. In MS, the MRI demonstrates the demyelinating lesions, which then guides in disease-modifying therapies. In seizure disorders, the EEG shows generalized spike and wave activity, which leads to the diagnosis of generalized epilepsy. You will then implement seizure precautions in these patients. Subarachnoid hemorrhages. An angiography identifies aneurysm, and neurosurgery or endovascular coiling. Diagnostic tests help give us the picture behind the symptoms. Knowing which tests to expect and anticipate, and know what each test tells us helps us anticipate complications, prepare patients safely, and intervene quickly when seconds matter. There are 4 advanced neurological diagnostic tools that are used when routine assessment is just not enough. These tools help us detect subtle neurologic changes, guide treatment, and prevent secondary brain injuries. ICP monitoring measures the pressure inside the skull. Normal ICP is 5 to 15. Anything over 20 is dangerous and requires immediate action. The ICP tells us that there are trends in brain swelling, response to treatment, and even early signs of herniation risk. A TBI patient with an ICP of 22 and a dropping level of consciousness requires airway protection, head of the bed elevation, and urgent provider notification. Evoked potentials measure electrical activity in response to visual, auditory, or sensory stimulation. They tell us if the pathways are intact. This is commonly used for MS, spinal cord injuries, or even interoperative monitoring to protect nerve pathways. In suspected MS, a delayed visual evoked potential supports demyelination. The transcranial Doppler, or TCD, measures cerebral blood flow velocity through the major brain arteries. This is used in stroke evaluation, vasospasm monitoring after a subarachnoid hemorrhage, and even when assessing cerebral autoregulation. A post-aneurysm patient may develop vasospasm around day 5 to 7. TCD detects increased flow velocity before any symptoms appear. This allows for early intervention. Continuous EEG records electrical brain activity over hours to days. This is important when detecting non-convulsive seizures, monitoring sedation depth, or even identifying subclinical seizure activity post-trauma, stroke, or status epilepticus. Which test would identify seizures that don't produce visible shaking, and why? Remember to always prioritize airway and breathing, prevent secondary brain injuries, know the rapid stroke or neurosurveillance, and know to trend data. A single vague data point means nothing. These priorities align with critical neuro care principles. Advanced diagnostic tools allow us to see what the exam cannot. ICP monitoring warns of swelling, evoked potentials reveal damaged pathways, TCD identifies blood flow threats, and continuous EEG catches those silent seizures. It is our job as the nurse to protect the patient and the brain. GCS provides a quick, standardized way to quantify consciousness after a neurologic injury. We score 3 responses: eyes, verbal, and motor, and then sum them to trend severity and guide priorities. So with eyes, 4 is spontaneous, 3 is to voice, 2 is to pain, and 1 is to no eye opening. For verbal, 5 is oriented, 4 is confused conversation, 3 is inappropriate words, 2 is incomprehensible sounds, and 1 is no response. Lastly is motor. 6, they follow commands such as take your eyes only and follow my finger as I move it right to left. 5, they will localize pain. 4, withdraws to pain. 3, abnormal flexion or decorticate positioning. Abnormal extension or decerebrate positioning. 1 is no motor response. With a GCS, the higher is better. So why would a Falling GCS matter. It often precedes other deterioration. In rising ICP, remember, the earliest sign is typically a change in level of consciousness. So when you check your patient, you want to prompt, can you open your eyes for me? Can you tell me where you are? Always protect the airway first. In a GCS, equal or lower than 8, always anticipate airway. You want to make sure you're trending your GCS, not just getting a snapshot. Using GCS to speak a common neurologic language. Score it accurately, trend it relentlessly, and act fast when it drops. We will review the following case study in class. Make sure that you are prepared to know how to rate the GCS of this patient, as well as what your priority nursing action would be. Let's talk about some medications, surgical options, rehabilitation strategies, and even essential safety measures. As nurses, we must understand why each therapy is used and how our actions prevent secondary neurological injuries. Medications such as anticonvulsants are used to treat or prevent seizures. The purpose is to stabilize neuronal firing. A patient with new onset seizures is started on valproate. The nurse monitors for sedation, mood changes, and ensures no abrupt withdrawal, which could trigger status epilepticus. Analgesics and anti-inflammatories are used for headaches, neuropathic pain, and spinal disorders. Levodopa and carbidopa improves motor symptoms. Oops, sorry, I skipped one. A patient with a spinal stenosis receives an anti-inflammatory medication to reduce the pain and increase mobility. Medications for Parkinson's disease. Levodopa and carbidopa improve motor symptoms. Giving on time to prevent off periods, the nurse avoids giving with high protein meals to prevent absorption issues. Cholinesterase inhibitors are used for Alzheimer's. These slow the cognitive decline. You want to teach family that these meds have a slow progression and they do not cure dementia. MG medications improve neuromuscular transmission. They're given 30 to 60 minutes before meals to improve swallowing and prevent aspiration. Surgical interventions are used when structural problems affect neurologic function, such as a craniectomy for brain tumors or hematomas, a spinal decompression for spinal cord compression. A patient with cord compression and ankle clonus undergoes emergent decompression to prevent permanent paralysis. Rehab is essential for stroke, spinal injury, and neuromuscular disorders. These can include physical therapy, occupational therapy, gait training, or even the use of assistive devices. A stroke patient with right-sided weakness benefits from early mobility and PT to prevent contractures and improve independence. Safety measures are key. Fall precautions for weakness, neuropathy, and Parkinsonian gait. Seizure precautions for seizure disorders. Aspiration precautions for stroke, MG, or ALS. Pressure injury prevention for all immobility. A patient with MG has impaired swallowing late in the day. As a nurse, you will implement aspiration precautions, monitor respiratory status, and give medications before meals. Think about which therapeutic measure must be implemented first for a patient with decreasing level of consciousness. Medications, mobility, or safety measures, and why. Your assessment on a patient post-TBI shows worsening level of consciousness and increased ICP. This indicates brain swelling and requires immediate intervention. As the nurse, you will elevate the head of the bed 30 degrees, notify the provider, and minimize stimulation in the room. As a nurse, you want to always emphasize safety and prioritization. Airway and breathing is always first. Preventing complications and adhering to medication therapy. Therapeutic measures in neurologic care aim to stabilize the brain, preserve function, and prevent complications. Nursing actions always emphasize safety, followed by monitoring, and are essential to ensuring these treatments work effectively. Let's go over a few red flags that require urgent assessment and immediate provider notification. These symptoms are indicating potential threats to cerebral perfusion, increased ICP, stroke, or even acute neurological deterioration. Recognizing these early can prevent permanent disability or even death. Unequal or non-reactive pupils can indicate brain herniation or cranial nerve 3 compression. Sudden confusion or decreased level of consciousness is an early indicator of rising ICP or even a stroke. New onset weakness or paralysis, especially unilaterally, is a classic stroke symptom that requires immediate CT imaging. Seizures or even severe headaches may indicate hemorrhage, infection, or increased ICP. These symptoms always require urgent escalation because they can reflect brain tissue at risk. Think about if a patient suddenly becomes harder to arouse. What is your first action? Think about your ABCs and emergent versus urgent. Let's link to your prior knowledge. A patient suddenly becomes confused with unequal pupils and new right arm weakness. Your action is to activate stroke protocol or ICP emergency pathways, maintain that airway and oxygenation, and prepare your patient for testing. Airway is always first in any neuro decline. A new neuro deficit is an emergency. Time is brain. Rapid imaging and provider notification are essential. You always want to prevent a secondary injury. Maintain the head of the bed at 30 degrees, avoid stimulation, and keep the patient NPO if they can't swallow. These actions align with the top priorities emphasized in neuro. Neurologic red flags are the earliest cries for help from the brain. It is our job as nurses to recognize them immediately, protect the airway and perfusion, and to activate emergency pathways fast enough to save tissue and function. We will review this case study in class as well. Please be aware of what the interpretation is and what your priority nursing action will be. For this case study as well, I want you to note the interpretation, whether this is emergent, urgent, or chronic, and what the priority nursing actions would be. The NIH Stroke Scale, or NIHSS, is our standardized tool for assessing the severity of a stroke. This helps us measure neurologic deficits, communicate clearly during stroke alerts, and monitor changes over a period of time. The NIHSS is used to identify how severe a stroke is, determine eligibility for thrombolytic therapy, provide a baseline for comparison, and to track improvement or deterioration over time. What does it measure? It measures the level of consciousness, orientation and the ability to follow commands, gaze and field visual, facial symmetry, motor strength in arms and legs bilaterally, limitaxia, sensory function, aphasia, dysarthria, and neglect or inattention. The higher the score, the more severe the neurological deficit. Does a higher NIHSS score indicate a better or worse neurologic status, and why? Let's link this to prior knowledge. Acute stroke signs such as facial droop, arm weakness, and slurred speech are presented by your patient. These deficits correlate with specific NIHSS sections of facial palsy, motor arm, and dysarthria. You want to perform a full NIHSS. You're going to call a stroke alert and prepare your patient for testing. Collect the last well-known time. This reinforces clinical reasoning in neurologic emergencies. Let's highlight the top nursing priorities. Rapid stroke identification, maintaining airway and breathing, immediate activation of protocols. You want to remember, why is it important to take the last known well? Is it more important than the symptom severity? Remember to always protect the airway and to always rapidly activate the stroke protocol. For this patient, I want you to know what the interpretation and the priority nursing actions would be, as well as the potential treatments. Intracranial pressure, or ICP, refers to the pressure within the skull caused by three components: brain tissue, CSF, and blood. Because the skull is a fixed space, if one of these goes up, the others must go down. This is the Monroe-Kelly doctrine. Remember, normal ICP is 5 to 15. Causes of ICP: trauma or TBI, tremors or masses, cerebral edema, hydrocephalus, or even bleeding, subdural, epidural, or intercerebral. These conditions reduce space inside the skull and cause an increase in pressure. The earliest sign of increased ICP is change of level of consciousness, often followed by a headache, restlessness, sluggish pupils, or even mild weakness. Late-stage symptoms include the Cushing's triad, the high systolic BP with a widening pulse pressure, bradycardia, and irregular respirations, even fixed or dilated pupils and posturing. Any sudden change in pupils or level of consciousness requires immediate action. Nursing interventions. Your role is to prevent further increase in ICP and monitor for changes. Again, we're going to put that head of the bed up 30 degrees and put the neck midline. We're going to avoid hip flexion and tight collars. We want to maintain a quiet, low stimulus environment. Cluster care to avoid overstimulation. Monitor level of consciousness, pupils, and motor response. Watch for Cushing's triad. Restrict suctioning unless absolutely necessary, as this raises ICP. Ensure adequate oxygenation and monitor for signs of herniation, pupil changes, and decreased level of consciousness. Patient education. ICP is the pressure inside your skull. When it gets too high, your brain can't function. Patients and families should watch for more sleepiness than usual, confusion or personality changes, severe headaches, vision changes, vomiting, and even unequal pupils. What helps to lower the pressure? Keeping the head of the bed 30 degrees, if allowed. Avoid bending forward. Keeping a calm, quiet room. When to get help? Call the nurse or provider immediately if the patient is hard to wake or confused, has unequal pupils, has very slow or fast breathing, or has a seizure. For this case study, we will discuss the interpretation, the assessment interpretation, as well as what we're going to document. We're going to go and review our seizures. A seizure occurs when there is a sudden, uncontrolled burst of electrical activity within the brain. They may affect movement, awareness, behavior, or sensation. While some only last seconds, others can progress into a life-threatening emergency. Seizures can be focal, which begin in one part of the brain, or generalized, affecting both hemispheres. Causes of seizures may include a chronic condition such as epilepsy, stroke, brain tumor, a TBI, a fever in children or an infection, metabolic issues such as low glucose or low sodium, and even drug or alcohol withdrawal. The symptoms depend on the type of seizure. For focal seizures, you may see twitching of one limb, staring or confusion, repetitive movements, or the patient may just remain partially unaware. Generalized seizures, such as tonic-clonic, have a stiffening, which is your tonic, and a rhythmic jerking, which is your clonic. Patients may become incontinent or even bite their tongue. An absence seizure is a brief staring spell. A myoclonic seizure is sudden, short jerks. During the postictal phase, expect your patient to be confused, have a headache, be tired, as well as maybe even some temporary weakness known as Todd's paralysis. Nursing interventions during a seizure. Your top priority is safety. It is not to stop the seizure. You want to protect the airway, protect the head, loosen clothing, ensure a safe environment, and time the seizure. Remember, we don't restrain or put anything in the mouth. After the seizure, we want to keep their patient on their side. Think about why. We want to reorient them when they're awake, checking their vital signs and assessing for injuries. We want to make sure that we document the onset, duration, movements, level of awareness, and recovery of this seizure. There are several treatments. They could be anticonvulsants or even benzodiazepines. If this was caused by a low glucose or a low electrolyte such as sodium, replacement of those and correcting the metabolic causes is your treatment. We always want to treat the underlying condition. If it's infection and fever, we want to make sure that that is controlled. Patient education during seizures. Explain to the families and patients in simple language what to expect. A seizure is an electrical surge in the brain. It may cause shaking, staring, collapse, or even changes in awareness. Explain what to do in a seizure, stressing to stay calm, rolling the person on their side, place something soft under their head, remove nearby objects, time the seizure. Do not restrain or put anything in their mouth. Call 911 when the seizure lasts longer than 5 minutes, when breathing is not returning to normal, when the person is pregnant or injured, or when they have a repeat seizure without recovery, and if it is their first seizure ever. How to prevent future seizures? Take medication on time, avoid skipping meals or becoming overtired, limit alcohol, manage stress, get enough sleep, and avoid known triggers. Seizure precautions are important. Keeping airway equipment at bedside, pad the side rails and keep the bed in the lowest position, maintain IV access for rapid medication administration, remove clutter and ensure a safe environment, keep the call light within reach, frequently round, and for high-risk patients, supervise ambulation and breathing. During a seizure, turn the patient to the side to maintain their airway. Protect the head without padding. Loosen tight clothing. Do not restrain movements or place anything in the mouth. You always want to make sure that you are timing your seizures and noting any characteristics. You have a 28-year-old who's admitted for monitoring and is confused after a tonic-clonic seizure. The nurse places the patient in a side-lying position and performs vitals and documents the event. You have a stroke patient with dysphagia who suddenly begins jerking movements. You, as the nurse, will initiate seizure precautions and maintain the airway. You have a patient with a sodium of 118 who develops twitching and seizure-like activity. As the nurse, she will prevent aspiration and call the provider immediately. Always remember that seizures can occur without warning. Stay calm, roll to the side, and protect the head. Never hold the person down, and don't put anything in their mouth. Call 911 if a seizure lasts longer than 5 minutes, repeats, or if breathing does not return to normal. So why is turning the patient onto their side during a seizure the first priority? Remember, neurosafety first, airway before anything. Always airway, safety, observation, documentation. For this case study, we will talk about important immediate nursing priorities, what to do during the seizure, and what to do after the seizure, as well as patient teaching. Chronic autoimmune disorders, where the antibodies attack the acetylcholine receptors at the neuromuscular junction, which then causes a fluctuating skeletal muscle weakness that worsens with activity and improves with rest. Key symptoms would be ptosis or drooping eyelids and diplopia, facial weakness, difficulty chewing and swallowing, fatigue with repetitive movements, generalized weakness, and these patients are at a risk for respiratory compromise. Diagnostics, EMG, a CT of the chest, and an acetylcholine receptor antibody test. Treatment is going to be based on the diagnosis. Nursing interventions: assess breathing and ability to cough, encourage rest periods and cluster ADLs, maintain aspiration precautions, and teach the difference between myasthenic and cholinergic crises. Major neurocognitive and neurodegenerative disorders, which include progressive conditions such as Alzheimer's disease, ALS, and Parkinson's. These disorders are chronic and worsen over time and affect mobility, cognition, behavior, and a combination of all three. As an LPN, your role is focused on monitoring for changes, ensuring safety, supporting ADLs, and providing ongoing patient and caregiver education. A major neurocognitive disorder, including Alzheimer's, is often referred to as dementia. It involves progressive decline in memory, reasoning, language, and the ability to perform daily tasks. Key symptoms are memory loss, short-term memory loss early on, difficulty with language, problem solving, and judgment, personality or behavioral changes, wandering or safety risks, and in later stages, difficulty eating, swallowing, or mobility loss. Behavioral management and routine establishment is important as part of the treatment and management plan, as well as environmental safety modifications. Nursing intervention includes maintaining structured routines and a calm environment. Use cueing instead of quizzing, like let's go brush our teeth. Ensure safety and prevent wandering. Support ADLs with step-by-step instructions, and provide caregiver teaching and respite resources. ALS, which is amyotrophic lateral sclerosis, is a progressive motor neuron disease causing loss of voluntary muscle control. Key symptoms are muscle weakness that begin in the limbs, muscle twitches, dysarthrasia or dysphagia, progressive respiratory weakness. They will be aware of their decline. They have an intact cognition. There is no cure, but medications may slow the progression, and the focus is maintaining function, communication, and respiratory health. Nursing interventions include to monitor respiratory status, closely reporting any decline, assist with communication devices such as during speech declines, provide aspiration precautions upright during meals and small bites, range of motion exercises to prevent contractures, and emotional support for the patient who remains cognitively aware of their declining health. Parkinson's disease is a neurodegenerative disorder caused by dopamine loss in the basal ganglia. Signs and symptoms, again, are tremor, rigidity, pill rolling, bradykinesia, postural instability leading to fall risk, sleep issues, constipation, mood changes, and even cognitive changes in later stages. Treatment focuses on exercise therapy and mobility training. Nursing interventions are the fall precautions, encouraging physical therapy and daily stretching, allowing extra time for ADLs, and monitoring for medication side effects, as well as giving levodopa on time with avoidance of those high protein meals. Patient education for Alzheimer's and MND. Memory and thinking problems gradually get worse. Use routines and simple instructions. Keep your home well lit and clutter-free, and report any new agitation, wandering, or swallowing problems. Medications may slow the decline, but don't cure the condition. ALS education includes muscles become weaker over time and breathing becomes harder. Report any shortness of breath. Use small bites and slow eating to prevent choking. Use mobility aids and energy-saving strategies. And communication devices may help as speech becomes difficult. Parkinson's education as movements become slower and stiffer. Take medication exactly on time every day. Avoid falls by moving slowly and using support as needed. Exercise helps maintain mobility, and report any new hallucinations, dizziness, or medication side effects. Alzheimer's disease is a progressive major neurocognitive disorder involving decline in memory, thinking, and ability to perform daily activities. It is the most common cause of dementia. The pathophysiology is a neuronal loss in the cerebral cortex and hippocampus, accumulation of amyloid plaques, and neurofibrillary tangles. This leads to impaired communication between brain cells. Key symptoms are short-term memory loss as an early sign, difficulty with problem solving, judgment, and language, personality and behavioral changes, wandering disorientation, and even late stage will have swallowing difficulty and total ADL dependence. The treatment, cholinesterase inhibitors, slow decline and do not cure. Structured routines and environmental modifications, and supportive behavioral interventions. Nursing interventions include using cueing instead of quizzing, maintaining consistent daily routine, providing a safe environment with locks, lighting, and removing hazards, promoting orientation with clocks, calendars, and simple explanations, and caregiver support to teach burden-reducing strategies. Parkinson's disease is a progressive neurodegenerative disorder caused by loss of dopamine-producing neurons in the basal ganglia. The cardinal motor symptoms are tremor or pill rolling, rigidity, bradykinesia, slow movement, or postural instability, which increases the fall risk. Non-motor symptoms are sleep disturbances, constipation, mood changes, and cognitive decline in later stages. Levodopa-carbidopa is a medication used to improve movement. Dopamine agonists are also used, as well as PT and OT for mobility, flexibility, and ADLs. A nursing intervention is to give levodopa on time and avoid near high protein meals. Implement fall precautions, encourage exercise, stretching, and slow movements, allow extra time for ADLs, and monitor for orthostatic hypotension and hallucinations. Migraines are a chronic neurological condition that cause severe, recurring headaches, often accompanied by nausea, sensitivity to light and sound, and functional impairment. Migraines are not simply a bad headache. They follow a addictive pattern with triggers and distinct stages. Migraines typically progress through 4 stages. The prodromal phase, which lasts hours to days before, has fatigue, mood changes, food cravings, and even neck stiffness. The aura, which is a visual or sensory disturbance, but not all patients have this stage. The headache phase itself, which includes intense throbbing, it's often unilateral, made worsened by movements with nausea, vomiting, and photophobia. Postdromal may have exhaustion, confusion, or mild headache after an attack subsides. Some common migraine triggers are stress, sleep disturbance, meaning too much or too little sleep, hormonal changes, weather changes, dehydration, certain foods, and even bright lights or loud noises. Migraine treatments can include acute or abortive measures. Triptans are the first line for moderate to severe attacks, followed by NSAIDs, antiemetics for nauseousness, and even a quiet, dark environment with cold packs. Preventative treatments may include topiramate, beta blockers, certain types of antidepressants. Nursing interventions are to encourage a headache diary. This helps your patient identify triggers, promote sleep hygiene and stress management, provide a quiet, darkened room during an attack, assist with medication timing and monitoring for side effects, and encourage hydration and regular meals. When teaching patients or caregivers about migraines, explain that a migraine is a type of severe headache caused by changes within the brain. It often comes with nauseousness and sensitivity to light or sound. Migraines tend to come in patterns and may have triggers. Patient education includes keeping a regular sleep schedule, drinking plenty of water, avoid skipping meals, limit caffeine and known food triggers, reduce stress with breathing exercises, relaxation, or stretching, and track the headaches in a migraine diary. Educate on what to do during a migraine. To rest in a dark, quiet room, use a cold pack on the forehead or neck, and to take medication at the first sign of symptoms. Seek help immediately if this is the worst headache of your life, you have a headache with fever or neck stiffness, new weakness, numbness, or trouble sleeping, or if it is a new headache after the age of 50. Spinal disorders is that which includes any condition such as low back pain, herniated discs, spinal stenosis, and spinal tumors. These disorders are extremely common and range from mild pain to neurological emergencies. Our role as nurses is to identify red flags, support safe mobility, and teach proper body mechanics, as well as to know when a patient requires urgent assessment. Low back pain is one of the most common reasons adults seek care. It can be caused by a strain or sprain, degenerative disc disease, arthritis, or even a herniated disc. Typical symptoms include localized pain, pain that worsens with movement, muscle spasms, and reduced range of motion. A herniated disc is when the disc material pushes out and irritates spinal nerves. Symptoms include shooting pain down the legs, which is sciatica, numbness or tingling, and weakness in the foot or leg. Spinal stenosis is a narrowing of the spinal canal, which compresses the nerves. Back pain with standing or walking, relief when bending forward, and tingling or weakness in the legs. Spinal tumors can be extradural, intradural, extramedullary, or intramedullary. Tumors may cause night pain, progressive weakness, or even changes in bowel and bladder function. Red flags that require immediate evaluation is new bowel or bladder incontinence, saddle anesthesia, which is numbness of the inner thighs, fever with back pain indicating a possible infection, severe or progressive weakness, trauma plus neurological deficits, unexplained weight loss. These findings may indicate spinal cord compression or cauda equina syndrome, which must be escalated immediately. Diagnostics commonly used: an MRI, a CT, an X-ray, or even labs if infection or malignancy is suspected. Nursing interventions: pain management, heat or ice, NSAIDs if ordered, and position for comfort. Body mechanics: teaching to bend at the knees, avoid twisting, and maintaining a neutral spine. Fall prevention for patients with weakness or numbing. Mobility encouragement: walking short distances when able. Assess for neuro changes: strength, sensation, gait, and reflexes. When tumor or compression is suspected, escalate immediately. For severe pain, maintain comfort, prepare patient for imaging or surgical consult. Patient education: what they should know. Most back pain improves with gentle movement, heat, and proper posture. Avoid prolonged bed rest as it often makes symptoms worse. Use a firm mattress and a supportive chair. Protect your spine by lifting with legs, not your back. Keep loads close to the body. Avoid twisting motions, and take breaks during long sitting or standing times. Seek care now if you have sudden bowel or bladder loss, fever plus back pain, numbness between the thighs, or pain after a fall or trauma. Self-care at home includes alternating between heat and ice, short walks every 1 to 2 hours, light stretching, maintaining a healthy weight, and wearing supportive low-heeled shoes. A TBI is a traumatic brain injury that happens when an outside force injures the brain, such as a fall, a blow to the head, or a penetrating injury like a bullet. TBIs can cause temporary or permanent damages in thinking, movement, and behavior. TBIs show up in 3 big categories: physical, cognitive behavioral, and sensory perception. Physical symptoms include headaches, nausea and vomiting, seizures or convulsions, muscle weakness or paralysis, loss of balance or coordination, slurred speech or difficulty swallowing, and drainage from nose or ears, which is a possible CSF leak. Cognitive behavioral symptoms are confusion, memory problems, personality or mood changes, and difficulty concentrating. Sensation and perception is blurred or double vision, sensitivity to light or sound, tingling or numbness. Red flags include worsening level of consciousness, unequal pupils, and Cushing's triad, which is hypertension, bradycardia, and irregular respirations, all of which signal an increased ICP. TBI treatment depends on the severity: mild, moderate, or severe. Here are the major approaches. Medical treatments include mannitol or hypotonic saline to reduce ICP. Anticonvulsants will prevent seizures, analgesics and sedation to reduce agitation and metabolic demand, possible neurosurgical intervention for hemorrhage or herniation risks, ventilation support if airways compromised. The diagnostics will be a CT and an MRI. Your nursing interventions for a TBI are to prevent a secondary brain injury, meaning prevention of hypoxia, hypotension, fever, high ICP, and even seizures. Priority interventions: ABCs. You're going to perform your frequent neuro checks, keep the head of the bed at 30 degrees and the neck neutral, maintain airway. We don't suction these patients as it increases ICP. Monitor for Cushing's triad and avoid overstimulation. You want to make sure that you are observing for CSF leaks from the nose or ears. Implement seizure precautions. Monitor for signs of worsening ICP, and report any sudden changes in level of consciousness. Remember, decreasing LOC is your earliest sign of trouble. Patient and caregiver education. Common symptoms to watch for: the headache, nausea, vomiting, dizziness, and sleep changes. Confusion to include memory problems, irritability, and mood changes. Vision problems, blurred or double, sensitivity to light or sound. If you have the red flags of worsening sleep or confusion, unequal pupils, seizures, repeated vomiting, a very bad headache, weakness or trouble speaking, Call 911 or return to the ED immediately. How to care for yourself at home. You need to rest your brain. You need to slowly return to school, work, and driving only with your provider's guidance. No alcohol or recreational drugs, as these slow healing and can mask your symptoms. Protect from another hit. No contact sports, ladders, or risky activities until you've been cleared. Keep the head of the bed elevated when resting to avoid straining or heavy lifting, which can raise your head pressure. Track symptoms in a daily log. Headache on a scale of 0 to 10. Sleep, thinking, bounce, and bring that to your follow-up appointments. Medications, take only what your provider prescribes. Some medications, such as sedatives, can hide worsening symptoms. Report any new seizures or worsening headaches. And make sure you keep all your follow-up appointments, as some symptoms appear days later. Always ask about a stepwise return to activity plan. Spinal cord injuries happen when trauma damages the spinal cord, which can lead to loss of motor function, sensation, or autonomic control below the level of injury. Symptoms of spinal cord injury depend on the level of injury and whether it's a complete or incomplete injury. Complete injuries equal total loss of motor and sensory function below the level of injury, could result in paraplegia or tetraplegia. Incomplete injuries mean that you have some sensation or movement that remains below the level of injury. This can include a central cord, anterior cord, or a Brown C-cord, etc. General SCI symptoms: paralysis and weakness, loss of sensation, loss of bowel and bladder control, pain or neuropathic burning, and difficulty breathing, especially with cervical injuries. The risk for spinal shock, which is flaccid paralysis and absent reflexes, and a risk for neurogenic shock, which is hypotension and bradycardia. The higher the injury, the more body systems that are affected. This is an emergency and requires acute management. Immobilization of the spine is necessary immediately to prevent further damage. With cervical injuries, you always want to give airway support. High-dose steroids may be used depending on the protocol. Surgery may include decompression or stabilization or even fusion. Long-term treatment is physical and occupational therapy, DVT prevention, bowel and bladder training, management of spasticity, neuropathic pain, and prevention of pressure injuries. Nursing interventions are focused on stabilization, respiratory support, preventing complications, and supporting function. Remember, for airway and breathing, we want to monitor the rate, depth, and pattern. Keep the head of the bed elevated at 30 degrees, assisting with coughing and deep breathing, and suctioning as needed. Spinal precautions mean log rolling only, no twisting or bending, maintaining cervical collar as ordered, keeping strict alignment. We're going to watch the hemodynamics. We want to watch for neurogenic shock. Report immediately if they have hypotension and bradycardia. We want to prevent complications by repositioning every 2 hours and performing range of motion to prevent contractures. We want to inspect the skin for breakdown and use pressure relieving devices. For T6 injuries and above, we want to monitor for autonomic dysreflexia, which is a severe headache, hypertension, sweating or flushing above the injury, and goosebumps below. This is a medical emergency. In all patients, we want to provide bowel and bladder care, timed voiding, straight cast schedule if needed, and adequate fluids and fiber for bowel program. Psychosocial support will provide emotional support as SCIs are life-changing. We want to encourage independence and involve family and the interdisciplinary team. Patient education is to focus on safety, breathing, skin, bowel and bladder, and when to call the doctor. Moving and feeling changes are expected below the level of injury. Possible breathing weakness with neck or cervical injuries, and the patient may need breathing exercises. Bowel and bladder changes, they'll need to learn a new routine to stay regular and dry. Skin care is vital. Feeling less means you're more at risk for pressure injuries. Daily care at home. Patients and caregivers will be taught spinal precautions with no twisting, log rolling with helper if ordered, breathing exercises such as their incentive spirometer, cough assisted, and head of the bed up at least to 30 degrees. Pressure injury prevention, reposition every 2 hours in bed, inspect skin daily, sit on a cushion, keep skin dry and clean. DVT prevention, doing leg range of motion as taught, and wearing devices or stockings if prescribed. Bowel program will be fibers, fluids, and scheduled toileting. Suppositories or digital stimulation if prescribed, and a bladder program of timed voiding or clean intermittent cath as taught. Pain and spasticity, medications may be taken as ordered. Report new spasms, pain, burning, or tightness. Autonomic dysreflexia is an emergency and has a very high blood pressure. If this happens, you want to sit up, loosen clothing, and check for a kinked catheter as it is common, and call 911 or your provider per your plan of care. If any new chest pain, weakness, fever with cough, or signs of UTI happen, these can then be followed with breathing trouble. Rehab and coping by working with PT or OT to maintain strength and independence, and ask about peer support or mental health resources. Polyneuropathy means damage to multiple peripheral nerves, usually in a stocking glove pattern, starting at the toes and fingers and moving upward. This is different from a single nerve injury. The most common cause is diabetes, but toxins, vitamin B12 deficiency, and autoimmune conditions like Guillain-Barré will also contribute. Symptoms fall into three big categories: sensory loss, which is numbness, tingling, burning, loss of vibration or position sense. Motor symptoms, overall weakness, difficulty walking, and foot drop. And autonomic symptoms, changes in sweating, heart rate, digestion, or bladder function. To diagnose polyneuropathy, providers may use an EMG and labs to check glucose, B12, thyroid function, and autoimmune markers. Nursing care focuses on safety and prevention of injury. Reducing sensation increases the risks for burns, cuts, and pressure areas, especially the feet. We teach patients proper foot care, help reduce fall risks, and encourage good control of diabetes when that's the cause. Explaining polyneuropathy for patients as a condition where many nerves are damaged. It can affect feeling strength and automatic body functions. Causes are diabetes, alcohol or toxins, low B12, and even autoimmunes. Common symptoms are numbness, tingling, or burning in feet or hands, trouble feeling hot and cold, muscle weakness or trouble walking, dizziness on standing, which is autonomic, and even bowel and bladder changes, also autonomic. Patient education includes checking your feet daily for cuts, blisters, redness, or swelling. Wear supportive closed-toed shoes and never go barefoot. Test bathwater temperatures to avoid burns. Keep floors clear using night lights to prevent falls. And report any new numbness, wounds, or weakness to your provider. How can patients manage their symptoms at home? Keeping blood sugar in target range. Take vitamins if prescribed, such as B12. Stay active with safe, low-impact exercises. Use pain meds or nerve pain medications only as directed. And ask about physical therapy if walking is difficult. Remember to call the provider with any new foot wounds, rapidly worsening numbness or weakness, trouble walking or new falls, and even dizziness that makes you feel unsafe.